Welcome to my presentation on the critical role of ventilation in designing and running operating theaters. Here's my disclosures. I'm a consultant to RVD Care. When you look into planning operating theaters, it goes much further than most of you might have expected. The upper right sketch shows you a drawing of a lot of technology that needs to be considered, usually hidden underneath the finished ceiling. For example, the entire air handling unit and ventilation system. But there is many more aspects to be considered when it comes to planning an operating theater. Operating theater projects are solution business. You have to bring together the project management and the logistics, the operating table, the clinical knowledge, the planning procedures, all the other equipment in the room, and for example in hybrid theaters also the imaging equipment, to come together to a solution that works for the surgeons. Therefore, you really have to consider the entire room as the system. Therefore, operating theater ventilation is not an easy task to plan, but it has significant impact on the patient's outcome. It is well known that operating theater ventilation can be linked to surgical site infections, and therefore the cleanliness of the OR room air is critical for the patient's outcome. Today, there are mainly 3 alternative ventilation systems available in the market. It's the classical turbulent mixing ventilation, as displayed on the left side, the classical low turbulence displacement flow, sometimes also called laminar airflow, and more recently, a concept that uses gravity, the so-called temperature-controlled airflow. The gravity is being used to create a directed downflow, similar to what you can see in the middle with the laminar airflow concept. Nevertheless, there still is a highly controversial scientific discussion on what effects especially laminar airflow technology has on surgical site infections. In conclusion today, the available evidence doesn't show benefits for laminar airflow compared with turbulent mixing ventilation in reducing the risk of surgical site infections in total hip and knee arthroplasties as well as abdominal surgery. However, the decision makers should really decide what is the best measures to reduce the risk of surgical site infections and what equipment could be used. Why is such a controversial discussion happening, and what might have an impact on the best outcome regarding operating theater ventilation systems? Well, the operating theater is impacted by several factors. It's a very complex thermodynamic system. The staff behavior, the changing environment, all play an important role in this context. Unfortunately, as of today, we don't have any uniform international standards to really validate and assess the performance of operating theater ventilation systems. Let's look into this a little bit deeper. It is known since the 70s that the reduction of surgical site infection can be achieved by reducing airborne bacteria. Sir John Charnley has demonstrated this, and Lidwell and colleagues independently showed later in the 90s again that the reduction of surgical site infections through antibiotic prophylaxis and improved air cleanliness can be achieved. At this time also, the definition for ultra-clean air was set at less than 10 colony-forming units per cubic meter of air. The main challenge in this context is the convection currents. Most surgical procedures have a similar setup, the patient lying on the operating table, and then there is staff around the patient, anesthesia staff, and circulating staff in the room. The majority of the generated colony-forming units is released by the staff very close to the wound and must be transported away from there to avoid surgical site infections. The effect of convection currents caused by the body temperature of staff is often neglected. This is illustrated by these two short videos. Here you can see the smoke rising because of the body temperature that heats up the air. When you have no ventilation system, as displayed here again, you can appreciate what happens with the body convection that, as I mentioned, is frequently neglected. Then, of course, the OR garment plays an important role. If you have tight cuffs at the clothing, this is also providing less release of colony-forming units by skin flakes. And then we have to look into the human behavior and the environment overall. The operating theaters don't look like this, what you can see frequently in brochures of OR systems manufacturers. Reality looks like this, and this is a highly complex environment, and maintaining asepsis in this context is not easy. Moreover, we know for quite some time that all equipment and the staff movements are really interfering with even the best ventilation concepts. Therefore, you need very robust ventilation systems, ideally to support reducing surgical site infections by the ventilation system. That this is also important is clearly demonstrated here in this little video. On the left, we see a live movie, on the right a CFD simulation. If you open the door, that completely changes the situation in the operating theater and significantly impacts the thermodynamic system. Also, the positioning of the equipment in the room has an impact on potential contamination of surgical trays. With the protected area of laminar airflow systems that usually is too small to cover all the equipment, there is a significant risk. This is even greater in rooms where there is no protected area and where the ventilation overall is not properly managed, as with turbulent mixing ventilation systems. It has been clearly demonstrated by Alsvit and colleagues that if you want to achieve the threshold for ultra-clean air, especially also in the periphery, as displayed here in this graph on the right. It is challenging even for the best laminar airflow systems. However, with the temperature-controlled airflow, it is a lot easier to maintain ultra-clean air in the entire room. This is mainly due to the interference and the flow of the air within the operating theater, as demonstrated here by this CFD simulations. You can clearly see that even though the low turbulence displacement flow, the laminar airflow, creates a nice protected area, with the turbulence in the periphery, it actually creates more problem than it resolves. Whereas the temperature-controlled airflow can maintain a continuous downward flow. This is also shown by these live experiments. On the left, you see what happens with introducing the smoke back into the protected area in a laminar airflow setup. Whereas with the temperature-controlled airflow, the smoke is not re-entering the protected area. Therefore, the periphery is much better protected, so the entire room is under control. Also, temperature-controlled airflow does a lot less interfere with equipment like OR lights, as displayed here. On the left in the video, you see how long, even one could say trapped, the smoke stays underneath the OR light. Whereas with the temperature-controlled airflow, this actually does not happen. In the right video, you can see that the OR light that is to be seen here in this area is not interfering at all, even when it comes to an area that you bring in the interference with the smoke directly underneath the OR light, as shown here. So temperature-controlled airflow almost navigates obstacles and maintains a good downward airflow. The limitations of conventional laminar airflow, as mentioned, are usually in the periphery, outside of the protected zone. There is a lot of issues, as have been demonstrated by many papers and as I showed to you in the slides before. Even if you mark the floor, then you can see and appreciate the problem. Moreover, in usual complex surgical environments, most of the time the equipment is not properly positioned within the protected area. Prior to marking, devices were in the clean zone only in 6.1% of surgeries. So therefore, it is absolutely critical to maintain ideal ventilation within the entire room. Unfortunately, the different international standards have no uniform validation or performance assessment methodology established. Here's just a list of several standards that are currently in use. The main difference of the approach is that with the German-speaking standards, measurement of protection degree or protected area is done in an artificial setup by using artificially generated particles, so it's no live situation. In other standards, like the Swedish standard, the total microbial burden of room air during surgery is being assessed in operation, whereas most of the Anglo-Saxonian standards only look at air changes. However, if you install ultra-clean air devices and achieve ultra-clean air, there is a high potential to reduce surgical site infections. In this calculation, if you reduce 10 times the level of microbial contamination, you could reduce the surgical site infections theoretically by 1.8%. Therefore, a reduction of 30% of surgical site infections might be attainable. We have looked at this in some studies together with colleagues in the Ukraine in a theater where we analyzed 1,000 consecutive cases before and after installation of a temperature-controlled airflow system. It was primary joint arthroplasty, and we could see a significant decrease in the surgical site infection rates from 3.1% to 1%. So let me conclude. It has been clearly shown by numerous studies that ultra-clean air, meaning less than 10 colony-forming units, has been shown to significantly reduce surgical site infections. Conventional ventilation, including laminar airflow, is challenged by vortices, heat convection, and movement of personnel, and does not maintain ultra-clean conditions throughout the OR. Temperature-controlled airflow systems combine the advantages of turbulent mixing ventilation and unidirectional displacement flow. So you have a protected area, but you maintain and manage the ventilation in the entire room. Therefore, temperature-controlled airflow leads to significant reduction of airborne microbial load in the entire OR, reducing the risk for surgical site infections. I firmly believe that regarding planning and qualification of operating theater rooms, the performance qualification is essential for the assessment of the effectiveness and efficacy of ventilation systems. Therefore, newer standards should actually address the real-life assessment of ventilation systems as the meaning for qualification and proper achievement of optimal patient safety. Therefore, again, keep in mind that high-tech operating theater projects are solution business, and the entire room is the system. Thank you very much for your attention.